I'm here at the ESH meeting on multiple myeloma here in Mandelieu in France, and I'm giving a talk about judging the value of a clinical trial. It's quite difficult, I think, for someone whose expertise is as a clinician and not as a statistician to make one's way safely through the forest of figures and the amazing amount of jargon that surrounds reporting of clinical trials. As a medical statistician, I think my role is to help clinicians understand these statistics and in particular be able to talk back to the statistic, to know when the statistic may not be telling you quite what you think it's telling you. And I think that nowhere is this more useful than in trying to judge a new treatment in a clinical trial. One of the things that one is often presented with is a p-value. And a p-value tells us the weight of the evidence. We say that if the p-value is small, then it's very unlikely that the result that you've seen could have occurred by chance, and so therefore it must be down to the treatment. So this assumes, of course, that the experiment is fair, and I think it's always useful to try and work out whether or not the experiment is fair, whether, for example, some patients have been excluded from one treatment group and not the other. We do a randomized trial to make sure that the patients are roughly equivalent, they're comparable. And that means that the differences are more likely down to the treatment than down to any differences in the profile of the patients. If you can see that there is evidence that intention to treat has not been used, then that means that the randomization doesn't apply anymore. But far more than that, there is a question not only of whether something is statistically significant, but also whether it is clinically relevant. And in particular, what do we make of a statistically non-significant result? Well, what we've said is that because p is not less than 0.05, then we say there is no evidence of a difference between the treatments. Now, p equals 0.05 means that 1 in every 20 trials or 1 in every test of a completely ineffective treatment would come up with a significant result one way or the other. So if you were comparing blue M&Ms and green M&Ms, if you ran 20 trials, you would expect on average to find that in one of those trials blue was better than green or green was better than blue. But what it doesn't mean is that if the p-value is bigger than 0.05, the drug doesn't work. So not significant is not the same as no effect. And we've seen that actually in acute myeloid leukemia recently. If one thinks about the recent licensing of gemtuzumab ozogamicin from the Alpha 0701 trial, then we know that although there was a significant benefit on event-free survival, there was no significant benefit on overall survival. That doesn't mean that gemtuzumab ozogamicin does not improve survival, because the meta-analysis of over 3,300 patients shows that there is a significant benefit in terms of survival. What it does mean is that the French Alpha 0701 study, only having 271 patients, and it was too small to actually detect a benefit in survival. There wasn't enough power to detect it. And so a small trial being not significant doesn't mean that the drug doesn't have an effect. It means that we have no evidence. So we need to instead to look at what we call confidence intervals, the likely range of the effect. And then you can find that a statistically significant result on a very large trial may actually have such a small effect in real terms that this is not worthwhile, particularly if one is dealing with a limited budget or there are associated extra toxicities. But likewise, a small trial which is not significant could be associated with a very great benefit or a very great harm. The other thing to think about as well is to look at only summary measures such as medians and hazard ratios. These make assumptions, and they make assumptions that the drug carries on working exactly as well over the whole course of the therapy and indeed beyond over the whole course of follow-up. So a hazard ratio of 2, for example, means that the death rate is doubled in one group compared to the other group. But of course this could be not true, and one could think of a treatment, for example, that has got a very high, or indeed some, early mortality, but is then curative. So if one goes historically back, one would think that transplant is a possible example here. And back in the old days, there was a significant transplant-related mortality, and so the survival curve for the transplant group would fall. But then the effect of the transplant kicks in and the curve levels out. Whereas people treated without transplant obviously don't get that early mortality, so the curve does better early on, but it of course is then doing worse later on. Now, depending on when one chooses to measure the hazard ratio, indeed how long one chooses to follow up, one's going to get a hazard ratio which is adverse early on, and then as the benefit of transplant kicks in, it will come through a point where it's neutral, and then with longer and longer follow-up, you hope that you are going to see something that actually shows an overall benefit at the end of the day. But the effect, of course, isn't constant there, and so the hazard ratio really doesn't tell you everything you need to know. And the same can be true of medians. If for example, you've got something which kills 51% of people and cures 49%, compared to something which is just letting the natural history of the disease run its course, your median is going to be worse in the curative, but actually the long-term outcome is going to be better. And it doesn't tell you the whole story. In fact, what you really want to say is, right, we have a potentially curative therapy, but only in half the patients. So how do we know who these half are? Because obviously that now is our lot of patients where there is the clinically unmet need. So I think what is important as a clinician is to not take any of these statistics on trust. Statistics is really trying to put a formal framework on common sense. And what I hope that I will be able to convey in the talk here in Mandelieu is the idea that common sense goes a long way, and that it is okay to query and argue back at a statistic and say, I don't think that what you've said is relevant to my practice. This is not a great black box where a lack of education in the arcane jargon surrounding it should actually prevent people from being able to answer back and criticize, just in a sense as there's a full and frank discussion between clinicians on clinical matters. So there should be a full and frank discussion between clinicians and statisticians on these statistical matters as well.